Good evening, everybody, and a very warm welcome. My name is Breatha Clifford from Healthcare 21, and it is a pleasure to host tonight's educational webinar, Clean It, Clear It, Control It, Winning the Fight with Wound Infection. It's a lovely evening out there today, so I'm just going to give it a couple of minutes and just see if a few more will join. Okay, so again, a very warm welcome to everybody. Managing wound infection remains a daily challenge across community and acute settings with significant implications for healing times, patient comfort and healthcare resources. This evening's session will focus on practical evidence-based strategies to recognise early signs of infection, optimise debridement and cleansing, and selecting appropriate dressings to support better outcomes. We are delighted this evening to be joined by our guest speaker, Dr. Leanne Atkin, vascular nurse consultant and associate professor with a joint clinical academic role at the University of Huddersfield and Mid Yorkshire NHS Teaching Trust. To say she has a passion for wound care wouldn't give it enough, and she has widely recognised with her work on improving assessment and management of complex wounds. So again, just before we start, I wanted to say a few quick housekeeping points before we begin. I'm joined as well this evening by my two colleagues, Paula Collins and Bill O'Brien. All microphones are on mute. The session will run for approximately 1 hour. We will aim to address the top 5 questions that you submitted in registration at the end of the presentation, and also hopefully have time for some more questions and answers. Any further questions, please pop them in the chat and we will do our best to answer those tonight, and if not, we'll follow them up next week. Following on from the question and answers, I will run through some of the dressing solutions we offer at Healthcare 21. Thank you again for joining us, and we have clinicians from all over Ireland joining us this evening. And now it is my pleasure to hand you over to the one and only Dr. Leanne Atkin.
Good evening, and thank you for that kind introduction. It's a beautiful evening here in Yorkshire, so I hope the weather's as good over in Ireland. So thank you so much for that introduction. So if we can, we'll just move to the slides. So my name's Leanne Atkin. I am a vascular nurse consultant and associate professor, but I am still a very passionate wound nurse. Yesterday, I was in a sweat box of an overbooked clinic seeing patients, and our clinic was running on average about 50 minutes over their appointment time. So I'm still very clinically active, and I'm still passionate at making a difference to every single patient that we see. And I think actually, if we start to think and try to prevent wound infection, we can start to win this battle. So today's session is all about how we can clean it, clear it, control it to try to win that battle when it comes to wound infection. Tonight, I'm going to take you on a whistle-stop tour about generalised information of wound healing, how to assess wounds, how to recognise non-healing, what actually is the complexity of the wound and the patient, and actually introduce you to the work from the International Wound Infection Institute in terms of therapeutic wound cleansing, active debridement, and that importance of considering that bioburden, that biofilm, and that bacterial load at each stage of your wound management. So I just want to start by reminding you what wound healing is. You'll have all heard this phrase, but I just want you to think about how complex this really is. We often think wounds should just heal, but actually it's a dynamic, natural, efficient process that requires the overlapping of various healing stages and a continuous sequence of regulatory mechanisms to bring about that ultimate healing of the wound. And if you just see that slide, the amount of cytokines, the amount of growth factors that's involved within wound healing is immense. So if anything I want you to take away from today is that wound healing isn't something that will just happen. It's something that we have to actively manage. We have to think about keeping our patients on that track of wound healing, and controlling wound infection is one of those things. You all know the 4 stages of wound healing: hemostasis, stopping of the blood loss; inflammation, where we get activation of the white blood cells, the inflammatory cells. We start to have the building blocks delivered in terms of wound healing. And inflammation is a good thing in normal healing wounds. We have proliferation that includes that granulation bed, and actually the proliferation stage includes the epithelialization of that wound. But we have to remember, when that wound looks healed to me and you, there's still a lot of remodeling, maturing of that tissue underneath to bring back its full function, the tensile strength, the heat, the sensation. Wound healing should look like this. But I just want you to think for a second, in your clinical practice, how do you assess a wound is healing or not? So how would you assess a wound is healing? Well, you hope to see a progression of images like this. You hope you start off with a larger tissue void and you start to see the wound filling up, cleaning up, reducing in size, getting to that stage where you can see actual skin coverage. But how many of your wounds actually make that progression in such a linear line without failure, with no problems at all? How many of you are seeing wounds that look like this week on week, day by day? And you're actually scratching your heads to say, does it look better? There is a change in that condition of the tissue. The wound edges seem to be changing. There's some evidence of healing, but is this wound actually on a progression to healing? And I think sometimes, or even the majority of the times, this is what we're faced with rather than that linear path towards wound healing. So I just wanted to look at some of those risk factors that makes a wound more hard to heal than one that's easy to heal. And there are certainly patient-related factors. There is healthcare resource-related factors. There's certainly treatment-related factors. But tonight's webinar is going to really focus on those wound-related factors and what we can do about those. And I think the first thing that we have to understand with any patient that we're managing within our clinical setting is the most important thing that we can do is to get the underlying etiology correct. What has caused this wound in the first instance? Because each of these images that you see, their underlying etiology is different and they require different things. There's a traumatic wound, a venous leg ulcer, an infected diabetic foot ulcer. There's a squamous cell carcinoma, there's end-stage peripheral arterial disease. And for each of those, we have to tackle that underlying cause before we can think about optimizing the actual wound management. But once we've considered that underlying cause, we then can start to look at how can we start to prepare that wound bed? How can we manage that patient to keep on that track towards healing, not allowing them to start to fail? And I think one of the best things that I was ever introduced is time, or timers, as it's now being referred to, because I think that this provides you an easy, structured, methodical, ordered, coherent, systematic approach to wound healing. And literally, it takes you 2 minutes in clinical practice to do this. It simply wants you to ask, is the tissue viable or non-viable? Is there any evidence of infection, inflammation? Do you have to be worried about that bacterial load? What's the moisture levels like? What's the wound edges doing? Are they advancing or not? And then there's a final stage in terms of repair. Where do we need to use advanced cellular products? Cellular products such as acellular grafts or additional matrices in terms of supporting that wound to heal. So I just want to take you through how simple this can be. So there's a simple question to ask yourself. When you think about time, the first is T. Is that tissue viable or non-viable? It's a simple question. Does that wound need debriding, yes or no? And you can see that we've got 3 wounds here, one with necrotic tissue, which is non-viable, one with sloughy tissue, which is non-viable, and one with granulation tissue, which is viable. But we've already categorized those wounds. In 2 of those, we need to do something with that non-viable tissue, whereas the other, we don't. And when we talk about necrotic tissue, it sometimes doesn't present in such an easy way to be able to determine. And there's different types of necrotic tissue that you will see. And you need to turn on your Miss Marple eyes, ears and minds to be able to determine what is the underlying cause of that necrotic tissue. So we have in the far left, we have vasculitis as the underlying issue. We have embolization of this digital artery that's caused that necrotic tissue. We have an ischemic foot. We have calcium deposits in the base of the wound that's causing that ischemic tissue. So not all of necrotic tissue looks the same. And it's the same as sloughy tissue. It all requires removing once you've considered the underlying cause, but it can look very different. Sometimes it can look snottier, sometimes it can look yellower, sometimes it can look quite like cheese on the top of the pizza. And sometimes it can be quite fibrotic, especially if you've got tendons below it, like you can see on that far right picture. And then granulation tissue, again, doesn't always look as beautiful as you can see it in that bottom picture on that leg ulcer. Sometimes your granulation tissue can look too beefy red. It can be quite friable. And these can all be subtle signs that we have a biofilm within that wound that we may need to manage. So even with granulation tissue that looks healthy, we have to really concern ourselves with what type of granulation tissue. So that third picture along, you can see it's much deeper claret colour. You can see the fragility because there's actually a little bit of hematoma on the base of that. That is not a healthy granulating wound bed. That is signs that there is bacteria within that wound that we need to start to manage. So I've spoken already about that bacteria, but actually this is the beauty of time. You've considered the tissue, so it's now time to consider the eye in terms of, is there any evidence of infection or inflammation? And we have to think about that in terms of all of the wound presentations that we see, whether that's a surgical site infection, whether that's a pseudomonas contamination from a venous leg ulcer, whether that is diabetic foot infection. And there's one thing I'd like just for you to consider. When we think about inflammation, inflammation is an active body's natural process. It happens on everybody, no matter what your skin tone is. But if you can see those two diabetic foot pictures that you've got, one of them, the redness is much easier to see, but because of the darker skin pigmentation, the redness is much more difficult to see. So we have to have increased vigilance with patients with a darker skin tone, because actually we might lose some of those signs of localized infection. Like I said, please don't think every redness means that there is an infection. Inflammation is part of your body's natural response. The trigger to that inflammation can be physical, it can be biological, or it can be chemical in terms of bacterial. So if you sprain your ankle or you go over on your ankle, you can have inflammation. That's not because of bacteria. It's simply because there has been a physical trigger within that. And we know within leg ulceration, many patients are misdiagnosed as having bilateral cellulitis because of that red inflammation you can see on that picture. But actually, they simply have venous hypertension that needs treating with compression bandaging. Remember the process of what happens in terms of inflammation. First off, inflammation is part of those 4 stages of wound healing I spoke about earlier on. Inflammation is good because it's that starting point of delivering all of the cytokines, all the white blood cells that act like little Pac-Man, ingesting the bacteria. They start as well, the inflammation, to trigger that cellular response, those biomarkers that we need to start stimulation of things like fibroblast blood cells and nerves. But the problem is with inflammation, it can increase the swelling within inside an area of concern, and it can be terribly painful for our patients. And we have to use our skill set to be able to say, is that natural inflammation or is that inflammation in relation to bacterial response? So Within those clinical signs of inflammation, you will often get all of these. You can often get lack of function, especially if you've got inflammation such as in your finger, because actually the swelling starts to prohibit the movement. You can get redness or heat because of that vasodilation. Your blood vessels widen to actually bring all those chemical mediators to the problem area. You get that swelling because you have an increased permeability between that membrane of with inside the vessel and outside the vessel. So we have an increased permeability, and we can often get swelling as a result of that. And because of that swelling, we often end up with pain because one of your inflammatory mediators is histamine, the other is bradykinin, and both of these, when they stick on a nerve end, they start to shoot chemical signals up that nerve fibre to give you pain. And again, I just wanted to demonstrate with you with two pictures of different skin tone, but you can still see redness in darker skin. It's more difficult to see, but if you look closely, you can see the difference in terms of there is subtle changes, and then there's certainly inflammation around the wound. And remember that every patient under the outer layer of the skin is the same colour. So we have to really start to think about actually reducing that skin tone bias to make sure that we're assessing every patient in the optimum way. So when you have acute inflammation, if that's due to infection, it often should settle just within a few days. If you have some form of bacterial infection, your body often responds to it without any problems whatsoever. The trigger for this is often a microorganisms. It's mostly your white blood cells that's involved, and one of three things will happen. You'll either get resolution, you'll get abscess formation, you'll get chronic inflammation. Within those two pictures that you can see on the right-hand side, they are both acute infection, and both of those do not require antimicrobial dressings. Both of those require antibiotic treatments because of the nature of the spreading infection along with that invasion of the host. Chronic inflammation, though, persists over a much longer period of time. You'll often find patients say it's the delayed onset. You'll ask them, when did your legs become red? And they'll say, I can't remember. It's been like this for weeks, for months, for years. It involves slightly different types of white blood cells. It's often mostly your fibroblasts and mononuclear cells that activate this chronic inflammation. With chronic inflammation, if it's not tackled at that moment in time, it will lead to tissue destruction, fibrosis of the structures of the skin, and it can lead to necrosis and skin breakdown. And along with infection and inflammation, there is this thing called biofilm. Now, biofilm has been around probably for around 2 decades. And in a way, biofilm is not new because biofilm is just bacteria. But I suppose biofilms are still relatively new because it's only been over the last 2 decades. But I think the knowledge in terms of how biofilm impacts wound healing is the biggest breakthrough we've had in chronic wound management over the last 2 decades. And we know this biofilm is a group of multi-species microorganisms that stick to the wound surface. They start to excrete a substance called EPS. I like to think of that. So you've got these bacteria sat within this protective bubble, if you like, of treacle, and therefore it becomes really difficult for that wound to make progress. And some of your antimicrobial dressings struggle to break through that EPS to be able to tackle the underlying bacteria. These are some of the suggested signs of biofilm. When biofilm first came out, we thought we could see it in terms of, I think that's a biofilm. You can't see a biofilm. You can only see a biofilm with a microscope. It's a microscopic structure. But you can certainly see the clinical impact of an uncontrolled biofilm. And these are all the clinical impacts of an uncontrolled biofilm. But I think the most telling time is actually if you've got that slough on the centre of the wound that keeps reforming, that slough becomes quite jelly-like that you can in a way peel off on the top. That's a huge indication of biofilm. If you've got uncontrolled Pseudomonas, that Pseudomonas will be living in a biofilm. And if you've got stages that are failing to start to epithelialize, that will be as a result of a biofilm too. And there's evidence out there that any chronic wound, 80% of them, healing will be delayed, because we need to really think about how we tackle that biofilm within our patients. The one thing I'd like, though, to remind you of is where we should be using wound swabbing, because a wound swab will not show specifically a biofilm. A wound swab will not show whether a wound is infected or not. The wound swab will only tell you if there is bacteria on the wound and what type of bacteria and what number of bacteria. That doesn't mean the wound is infected or not. The diagnosis of wound infection is a clinical diagnosis. So we should only be using a wound swab when we know that there is infection and we want to start that patient off on some antibiotics. We would take a wound swab, start them on empirical antibiotics, and then check that sensitivity down the line. Please remember the correct technique and when taking a wound swab. You should clean the area first. You should debride any devitalized tissue that you can. You should take the swab from the cleanest area that you possibly can. And you need to be swabbing for around 1 centimetre in size. That might be news to many of you, because I'm sure, like me, you don't want to cleanse that wound because you feel like I need to pick up that bacteria and you want to go for the most dirty aspect of that wound. That is not the correct technique for taking a wound swab. We need the clean areas to be able to look at exactly what species is there. So I just want to remind you, in terms of infection, when we're talking about is that wound infected, yes or no, it's a clinical image. It's a clinical picture. You can't make a diagnosis based on an image only. You need this information. If your patient's got signs of spreading infection, that is an infection. If your patient, though, has got evidence of Pseudomonas on a wound, but actually there is increased exudate, but the patient's feeling well, this is not a spreading infection. It doesn't require antibiotics. It requires treatment with appropriate antimicrobial dressings. So I just want you to really hone in on this infection and inflammation. And I want you to really start to turn up your diagnostic skills, thinking about whether this is infection or is this inflammation, and actually how do I manage that biofilm throughout the whole of this wound healing journey. So we've done the T, we've done the I, we're on to the M. And actually the M stands for, is the wound bed too wet or too dry? I work in lower limb management. My pain in the neck is gravity, if you like. I very rarely find a leg that's too dry. I find many legs, though, that's too wet. Remember that exudate isn't a bad thing. Exudate facilitates all those 4 stages of wound healing that I talked to you about at the beginning of this presentation. It contains all of those important cellular activators that we need. So it's not a bad thing. The difficult comes, though, is once a wound gets stuck in the chronic inflammatory stage, it then starts to increase the amount of exudate. And within the exudate, we start to have an increase in pro-inflammatory cytokines that start to actually impact on that wound's ability to heal. Within the lower leg, why is it such an issue? Simply gravity. And because you've got this capillary bed, we often find that wounds on the lower leg are larger in size, high amounts of exudate. The exudate is more viscous, more thick compared to other areas of your body. And because we have this inflammatory response, we have vasodilation within that capillary bed. We start to get more edema, overloading those lymphatics, and we start to have those wet, weeping legs. And we really need to think about how we address that maceration and how we optimize that patient. It has to start with eliminating the underlying cause. Why is that leg so wet? Because of the chronic inflammation inside, and the chronic inflammation is related to their venous hypertension. That patient needs strong compression. But we also need to think about, why is that maceration so bad? It's because we've got a high potency of bacterial load on the wound. We need some effective antimicrobial dressings. We've probably got poor dressing choice, poor frequency, and actually there will be a lack of effective skin barrier products within that patient. So moisture balance is really important, and protecting of that surrounding skin to prevent that maceration wherever we can needs to be mainstay within our clinical practice. But I just want to hone in on the management of wet legs. I hate the terminology wet legs. I hate it, because wet legs says that we should just be mopping them up. We really need to scratch our heads and consider why. Because actually, if you are managing a patient with a wet leg, their solution will be in compression bandaging. I appreciate we have to look at their arterial supply to what level of compression is allowed, but we need to be considering compression with any patient with a highly exuding lower limb wound. So that brings me finally onto the wound edge. And within the wound edge is often where we see the impact of a biofilm, because what we want is these nice beach edges where the epithelial cells will start to skate over. What we don't want to see is that undermining, that steep cliff edge, that callus edge, because that's where the biofilm will be living, and that's what's impacting our ability to wound healing. If you see a patient with a steep cliff edge, that wound will never go on to heal. We have to remember that there's always unusual reasons for wound edges that's not healing. So we have a candida infection, we have a squamous cell carcinoma, and we have pyoderma gangrenosum within those three pictures. So we have to, again, ensure we have the correct diagnosis with our patients. So I hope I've given you a whistle-stop tour in terms of how do you assess wound healing. We need to have individuals that are confident and knowledgeable. We need you to be able to recognise normal versus abnormal, when to escalate these patients. We need to, number one, have an accurate diagnosis. We need to make sure that we're addressing that to optimise a patient's wound healing. But then we need to be thinking about how can we improve the preparation of that wound by thinking the tissue, the infection, the moisture, and the wound edge. Because many of our patients get stuck in this chronic inflammatory cycle. And actually what we need to do as wound care practitioners is help them to move on with optimum wound management, reduction of that microbial burden to help them to stimulate that ultimate wound healing. Because when you look cellular about what stalls a wound from healing, there's only two things: increased MMPs and the presence of a biofilm. So if we can control those two factors, we can make more wounds from that chronic non-healing state into that healing state, simply by thinking of how do we control the inflammation and how do we reduce the biofilm. These biofilms are tricky because they sit in this EPS, and therefore they can really start to cause that chronic inflammation, increasing the exudate levels, and actually a lot of the cells become permanently asleep and they just fail to start to heal. And we've got to understand that as much as you may clean a wound brilliantly today, you could curette debride it. Within 24 hours, that biofilm will often be back. So we need to be thinking about how do we manage that biofilm both at dressing change, but also in between dressing changes. Because if you're seeing wounds like this that are stalled and static for healing, that is because of an uncontrolled biofilm. There is lots of information in relation to biofilms. These are some of the great documents. There's some QR codes coming up if you want to get your phones ready. And the International Wound Infection Institute that I am a board member of have done some fantastic documentation to help us to think about how do we think about wound infection in clinical practice. And they've come up with this fabulous continuum, if you like, because we have to recognise that every wound will have a degree of contamination or colonisation. There will be bacteria on that wound. If you swabbed that wound, you would find something on the wound swab, but that doesn't mean that needs treating. We have a middle ground when we're looking for local evidence of infiltration of bacteria, both covert signs and overt signs. And it's in this ground that we really need to be thinking about how do we prevent this infection from becoming spreading or systemic. And throughout all of this, there needs to be a consideration of biofilm. So these are the 2022 guidelines. Please watch out. This year, there's going to be a new set of guidelines produced that makes things a little bit clearer in terms of where we should be positioning things. It's not just the IWII, though, that's making this. I was the proud author of the wound hygiene strategy document. That led on to a best wound debridement best practice document. And we've just had the therapeutic and skin wound cleansing document from the IWII. And I'm so pleased that they are now talking about therapeutic wound cleansing, because we need to bring wound cleansing back. Within this document, it really starts to focus on the holistic care of the patients. What's the interventions that we can do to stimulate that wound bed, like the times that we've just talked about? How do we actually consider that infection prevention and management strategy at every single patient that we see? But it really starts to focus on this therapeutic wound cleansing and this need for debridement and the optimum wound dressing. We need, though, to think about one stage before that, if you ask me. And I just want you to remember that we need to bring prevention back into wound care. So I just want you to, for a second, to remember how important your skin barrier function is. The final cell of your skin is full of corneocytes. And what we need for them is we need them to be pumped and swollen, like pumped marshmallows. Because if we've got a smooth skin barrier, no gaps, we've got no areas where irritants or allergens can get into that skin. And to do that, we need to prevent the loss of moisture within our skin. So transepidermal moisture loss, if we have too much of this, we start to break down the mortar within our cells, within this skin barrier function. And actually, we need to be thinking about how do we ensure that we've got a beautiful skin barrier. And how do you do that? It's simply the application of emollients. At each and every dressing change, we should be thinking about how we restore that skin barrier function. And I want you now to see emollients as a vital part of everyday wound care within your patients. And would you know it, that the amount of evidence that's out there in terms of emollients is immense. We have high volumes of evidence to say that emollients are beneficial in all of those areas. Who would have thought a white little cream could be so important? But once we've thought about the emollients, we also need to be thinking about wound cleansing and cleansing of the surrounding skin. It sort of breaks my heart that this is the thing that seems to have been lost from clinical practice at this moment in time. And I'm so pleased that the IWI are bringing it back. We need to be cleaning wounds and cleaning it like you mean it. We need to be removing all of these skin plaques. We need to be applying emollients to these patients to help maintain their skin barrier function. Therapeutic wound cleansing is not simply about anointing a patient's leg with some saline. It's about really thinking about how do we stop this delayed wound healing? How do we reduce the microbial burden? How do we remove that necrotic tissue or that devitalized tissue that may be loose? And how, actually, if a wound is not therapeutically cleansed, we actually keep round that chronic inflammatory cycle. So cleansing a wound therapeutically is a huge advantage of moving that patient through that healing trajectory. And if you read this document, it starts to go through in details how that should be done. It asks us to really think about when we should be using wound cleansing and how we should be entertaining that wound cleansing. So it gives you this great theoretical model that we can use in every patient that we see to really ensure that we're doing the right care. But as part of this document, it starts to talk about therapeutic zones of cleansing. So we need to start in zone 1 of the wound itself. We need to then cleanse the peri-wound area, around 4 centimetres of the wound, and then we need to be cleansing for around 20 centimetres of the wound to help to reduce that bacterial burden. You need to be thinking about what's the most appropriate skin cleanser that you've got access to. you need to be thinking about what's its active therapy properties. Is it inert or is it active? What's its pH level? We also need to be thinking about what intensity and what technique do you need for therapeutic wound cleansing. But we certainly need to be wound cleansing back. This is just simple wound cleansing. This is nothing special. This is just 5 minutes of wound cleansing done therapeutically. And if this was your leg, which wound would you rather walk out of a clinic with? Which wound would you feel you are better cared for if you walk out of that clinic? Along with that, we need to be thinking about debridement. We know when you've got any devitalized tissue, then again, it's just going to delay that cellular response that you have within that wound. We also, when you've got devitalized tissue, it really inhibits the true visualization of how deep that wound is. So we need to be thinking about debriding those wounds. And you will have heard of mechanical debridement. This is simply 1 minute with a curette to be able to stimulate that wound healing. And when we talk about debridement, we should be taking it back to pinpoint bleeding. The difficulty is that actually for many generalist nurses, they have limited options of debridement. You might have options to some of these therapies, but actually many nurses do not have the option of accessing sharp or surgical debridement. But I just want you to remember that whenever a wound has got devitalized tissue within it, you're in a minor state. You're in a state where you've got a feeder for that bacteria. We need to get that wound to clean, to get it to day 0, if you like, because once we've got that wound clean, we then can progress to wound healing. So we need to be thinking about how do we debride that wound as quick as possible to be able to get them to point 0 to allow that wound to start to heal. I'm a great believer in correct debridement. If you are in charge of a service, please look at the evidence around this. They are cheap as chips, as we say here in Yorkshire. It is so satisfying to be able to remove all of this in a quick action. And actually, the competency to be able to do this is much smaller than using sharp debridement. So just take that information home to your service leaders to see if you could look at implementing correct debridement where you are. Obviously, we have to consider that correct debridement may not be suitable for all wounds. For any of these pictures here, you will not be able to correct debride them because of pain, because of the adherence of the tissue. And this is where we need the magic of wound dressings that's going to help us debride these wounds to get them to the point 0, especially dressings that's able to control that bacterial load at the same time as debriding these wounds. And we have certain wounds where you have to be extremely brave to be able to start any form of debridement. So just think about your underlying structures, think about what teams are wrapped around you, and if you have wounds of such complexity, I urge you to link with your fellow plastic surgeons, vascular colleagues, to be able to make sure that we're managing these patients in that wider multidisciplinary team. But with all of that, you will have heard me say the word bacteria again. And we really need to be thinking about this anti-biofilm strategy. This was the amazing work by Greg Schultz that he really talked about where we need to be using a form of anti-biofilm strategy throughout the whole process of wound healing. Sometimes that might be active antimicrobial dressings, but we should be trying to step down away from them as soon as possible to dressings more that's able to control that bacterial load on a regular basis rather than reduce that bacterial load. So I asked you to watch out for the new IWII document. It's coming out. But if you look carefully, this is already out there. This is the new 1 page that's come out. I like this because of a couple of things. It still gives you the information in terms of the infection, but actually it starts to talk about when we should be thinking about a potential biofilm, and it's brought in those clinical factors of what a potential biofilm is, and it's asking you to consider for a potential biofilm all the way from colonization up to spreading the infection. So this needs to be everyday practice within your wound care. It also brings in this step up, step down model of what type of strategies we have to be able to manage these patients in your clinical setting. So that QR code links to this single page PDF, and I find that extremely useful to have in my clinical practice. So I'm always considering the microbial level of the patients that I'm seeing. So I've introduced you to the new IWII. I've talked about therapeutic wound cleansing. I've talked to you about the need to debride a wound. And I've talked a little bit about antimicrobial wound dressings. I suppose the difficulty is within wound care is how many products do we actually need? Because do you need a wound cleanser? Do you need a debrider? And what's the evidence base for antimicrobial dressings? And are they truly effective in all states? I certainly think that we have a problem in terms of antibiotic resistance, and we have to be using those very wisely indeed, only on patients where there is signs of clinical infection. But actually, rather than using all of these products, maybe we need to start to do things more simpler. In terms of the antimicrobial dressings that you have available to you at this moment in time, there are many different active agents available to you. Be careful though, because the costs of these change dramatically. The evidence base for them isn't so strong in all areas. There is interesting evidence about toxicity and also of resistance, especially for silver resistance. And actually the overall cost-effective evidence for some of these can be questioned. So please be careful of overusing antimicrobial dressings. They are useful, but actually we need them to be positioned in the right place at the right time, only when we need that therapeutic active ingredients to reduce that signs of local infection. But maybe we need to be cleverer, because there are newer products that's being developed that provide a multimodal action. So they're not actually having issues with resistance or toxicity, because their mode of action is very different. They bind to the bacteria, they strip the bacteria away. Therefore, there's no risk of any toxicity or resistance. They're multimodal because they're actually able to help us with debridement at the same time as that bacterial control. And many of these have got a higher level of evidence in terms of effective studies. A lot of them has been produced over in Hull Medical School by the amazing team over there. But there's overall cost-effective evidence that these can actually reduce your risk, your levels of infection. So when I started talking about prevention earlier on, maybe we need to be thinking about multimodal products to keep that biofilm that we know that's going to be present at bay, helping to prevent that infection ever from occurring in that first instance. So I give you a whistle-stop tour about wound healing, an introduction to the importance of wound assessment, the complexity of wound healing. I've given you a lot of information in terms of that clinical complexity of that patient. And I just want to really end with how we started. Please remember that wound healing is complex. You are amazing healthcare clinicians that's watching this today. You have a brilliant skill set. We just need you to be activating that skill set, considering that bacterial load, thinking, actually, how do we clear it? How do we control it? How do we optimize healing in every single patient that you see, in every setting that you work? I hope you've enjoyed that session, and I'm going to hand back over now to the team at HC21, who's just going to give you a little bit of information in terms of their portfolio range. I'm still here though, so if you've got any questions, please send them over.
Dr. Leanne Atkins, everybody. Wow, what can I say? I was really, really excited about this evening, and you certainly did not disappoint. I have been so motivated with your presentation. Thank you so much. I'm going to give you a little bit of a deserved break, and I'm going to just give again a whistle stop presentation on our products. So if the guys could bring up our slides. So before we move on to the questions with Dr. Leanne Atkins, I'd like to briefly highlight some of the products that I suppose, really were discussed there during the presentation. Options available to support approaches we've discussed this evening. I'll just give a very quick overview now, and we'll follow up with emails and information and codes so that you have everything at hand. We also have 2 other wound care product specialists covering Ireland, and we'll include their contact details in the follow-up email also, so that you know exactly who to reach out for support, product queries, and training needs. We appreciate that in different areas of Ireland, there is different ordering pathway, but I just want to reassure you tonight that everything we talk about is available on the current HSE framework via your own stores. I'll now take a few minutes to walk through some of the key products in your range. So Sorbact is an antimicrobial free technology that works by physically binding and removing bacteria and fungi from the wound surface at each dressing change. So the focus is on reducing the bioburden and supporting the body's own healing without the use of traditional antiseptics. What does that mean? It means that it's a safer option for all of your patients. There is no known antimicrobial resistance, which is wonderful. So you can use it long-term on all of or at any stage of the infection continuum. So regardless of your wound type in infection stage, we have a product to suit that wound. And also, just to remind everybody that Sorbact can be used prophylactically as well, because it does not, I suppose, it doesn't donate a chemical to the patient. So if I could just have some of my images there for my Sorbact. No. So again, I want to say thank you so much for those of you that have logged on this evening. We're having a very unusual weather in Ireland at the moment, so I really do appreciate your time logging on this evening. So I suppose discussing our Sorbact range, okay? So the Sorbact technology applies to all of the dressings, but we have a ribbon gauze for your sinuses, poniidal sinuses, wrapping around digits, etc. We have a product for everything. So next slide there, please. And again, we have, so I suppose, first of all, just to say here with the best practice statement, don't take our word for it. You know, there's plenty of clinical data out there regarding Sorbact, which is a DAC dressing, physical mode of evidence, but we have a best practice statement that states all that as well. So we can pass on a copy of this to any of you that wish afterwards as well. So next slide, please. So again, talking about the infection continuum, Sorbact can be used at any stage of the infection continuum or at any stage of the wound healing. Next slide, please. So just to go back to our range in Sorbact, we have everything from ribbon gauzes. We have a contact layer that can be used as your first protocol. It can be used as a wide surface contact area. It can be used under the armpit, under the breast, in your groin area as your first protocol. Such a versatile dressing. For any of you those that knows me, you know this is one of my favorite ones. So it works on both, again, bacteria and fungi, not to forget that. We have got a pad for a Sorbact pad that so absorbs a level of exudate. Again, can be used under compression, can be used anywhere. We've got our Sorbact Hydro, which is our contact that's impregnated with a wound gel. So lovely for those dry wounds, those sloughy wounds, necrotic wounds. Really, really nice for that stage. We've Sorbact Hydro Active, which is lovely that if you need a dressing to debride, but also work on your infection. We've got Siltec Sorbact, which is a lovely foam dressing. It's got a border, so it's like a 3-in-1. You've got your antimicrobial therapy, your exudate management, and a lovely Siltec gentle border to hold everything in place. We've got Sorbian Sorbact. So any of you that know Sorbian, which is our exudate management product, we now have it in Sorbact as well. So it's a one-stop shop. We have Leukomed Sorbact, which is our post-op dressing in the Sorbact family. We have lovely evidence, again, in the whole Sorbact range, but when it comes to Leukomed Sorbact, we have specifically looked at the area of maternity. And the evidence that's come out of those studies have shown that we can reduce surgical site infections by over 50%. Last but not least, we have a lovely sorbian product there called Sorbian XL that's sitting in your NDC. It is accessible to you all via your stores. And again, it's managing that exudate for you. It can be used in conjunction with our Sorbact Contact if you require an antimicrobial therapy as well. Again, that's a very quick whistle-stop introduction to our range. We will follow up with some more information, but I would encourage you to reach out to your product specialist in your area. We're going to bring up a picture now of the three of us that covered the country. So you've got myself covering Munster, Kilkenny and Carlow. You've got Bill covering Leinster, and you've got Paula covering the West. So there is a lot of knowledge between the three of us, and we'd only be delighted to support you. So now I hope Leanne has had a well-deserved little rest there. I'm going to pass you over to my two colleagues, Paula and Bill, who are going to pass on some of your questions you submitted at registration. Thank you so much.
Good evening, everyone. Thanks very much again to Leanne and Brita for your brilliant presentations. I'm going to get straight into some of the questions that came through in the registration. We've just focused on 5 of the main questions. Some of the questions have already been answered as well in the presentation by Leanne. So thanks very much to Leanne for that. So the first question that came through is, what is the safest and most effective primary dressing for infected wounds?
If it was only just that simple, that there was one answer to that question, then wouldn't my life be easy? So again, I think it depends on what's the definition of infection. And I think that this terminology is used across the whole of that infection continuum. And the evidence for which product you need depends on where you are within that continuum. Is it just a colonized wound? Is it a wound showing overt or local signs of infections? Is it a spreading infection? And then on top of that, the treatment for those will be different. If you've got a spreading infection, we need to be reaching for antibiotics, not wound dressings. But if you get any of the other stages, it depends on where we are and what we're seeing. So we certainly want some form of antimicrobial dressing if we are in a local or covert. And we want some form of protection against infection across all of that continuum from colonization up to overt. But which dressing, to me, is more about actually what vehicle the product's on. So you've just talked to me about your product range, and you've got products that actually have an antibiofilm and antibacterial strategy, along with a dressing that can debride, along with a dressing of a superabsorber that can control exudate. So it really depends actually what's the condition of the wound that you're seeing to which is the most appropriate dressing. When you say effective, it's really difficult because there's been very little head-to-head studies across all of these. Certainly, if you go for an inactive antimicrobial dressing such as the Sorbact range, it certainly is going to be the safer because there is no evidence in terms of toxicity or resistance with that form of dressing because of its mode of action. So unfortunately, it's not a simple answer. It's an individual patient assessment, but you need to be thinking about what level of infection that you've got and what's the actual condition of that wound bed when you're choosing the most appropriate dressing.
Perfect. Thanks very much, Leanne. And the second question, how do you support and implement increased awareness between the different management of inflammation and infection to ensure that antimicrobial management, both local and systemic, are only requested or prescribed when there is evidence of infection?
I think the word infection is rather dangerous. I think we band it around a lot. And I think the problem is if anybody hears the word infection, they think antibiotics. And if I got told I had an infection, I would be saying, well, where's my antibiotics that go with my infection? In a way, I wish we had a different term for wound infection than infection, because actually we need to be really thinking, well, firstly, prevention. If we know these wounds are going to be colonised with something, and we know biofilm is a problem, to me, they should all be on a preventative strategy of something that's going to control that bacteria from day one. Rather than letting it get worse, let's prevent it from getting there. I think it's about talking to our clinicians in the same language, the same as our patients, of really talking about chronic inflammation and scald wound and localized infection rather than true infection. And I think that we need to stop doing wound swabs which show that you've got bacteria unless we really want to start that patient on systemic antibiotics. So I think we need to change our language first. I think it's dead easy to blame the patients for asking antibiotics, but I would look at ourselves. I don't think we've got the narrative that goes with this right yet within our clinical space. So we need to be sharing this message, and we need to be really thinking about that preventative strategy with all interventions of wound care.
Thanks, Leanne. That's a brilliant insight. And I suppose prevention is key. So in any situations with patients that we're looking after that are chronic patients, prevention is definitely the key takeaway point from that question. And we'll move on to question 3. So if you can please share some expertise on how you can control reoccurring heavy greenish exudate from a leg ulcer that is already being treated with compression, but keeps weeping and getting infected.
So again, just watch your words in terms of infection. You actually mean a local infection, not a spreading systemic infection, or you might actually mean they keep getting cellulitis. There's a couple of things for me. I just want to tell you my experience. So if I'd go back 10 years ago, my leg ulcer clinic on a Wednesday was covered with patients just like that. We all came out at the end of the day, our uniforms just used to smell of Pseudomonas at the end of the day, because we couldn't control it. We could never get on top of it. It was just always recurring, and we would never seem to get anywhere. We put a focus on good wound hygiene, good cleansing, good debridement, thinking about anti-biofilm strategies in all of our patients. When you're doing that on an irregular basis, at every single dressing change, you start to actually tip down that bacterial load. Rather than just put some silver on when it gets infected and take it off again when it's not, you're bouncing. Having that anti-biofilm strategy throughout the whole of your wound care, you start to see that tail off. But that's got to be at the same time as strong compression of at least 40 milligrams of mercury pressure if that patient's got a venous leg ulcer. And if they're not responding to 40, you might even need to step them up to 50 or 60. What's triggering that chronic inflammation inside that wound is the venous hypertension inside the body. We need to be treating that. Then we also need to be managing at the same time that bacterial load within that patient. There is no point in giving antibiotics to patients with Pseudomonas. It doesn't work. We need good wound cleansing, therapeutic wound cleansing, active debridement, and a long-term anti-biofilm, antibacterial strategy within those patients. So I'd urge you to have a read of that IWII one-page sheet that talks about stepping up and stepping down antimicrobials, and actually you might be able to gain some insights with that. But I know it's challenging, but I'd just say one thing: please don't give up. You sound like a great advocate for your patients, so please keep going. I know it's difficult, but you can get there.
Hi, Leanne. Thanks very much. Yeah, no, I know that clinician. I would agree. She's a fantastic clinician and has a lot of tools at her disposal. So I think from what you're saying there, it's not just one approach, it's using multiple approaches, all the tools you have in your toolbox. Grand, let's move on to the next question then. What's the best way to safeguard the peri-wound from maceration in a high exudating ulcer?
Well, the first thing is make sure you're managing the underlying mechanism of pathophysiology. And if that wound's in a leg, that patient's going to need some compression. If you think you're compressing it and it's still highly exuding, they're going to need higher, stronger levels of compression. Obviously, that needs to be on an individual patient risk assessment in line with what's their arterial status. So get the underlying cause right first. Think about how actually are you managing that underlying cause. In terms of that peri-wound edge, absolutely, you need to protect it really well. There are skin barrier products that you can use. There are some advanced skin barrier products that's available. They are like tissue glues that can go on surrounding a wound, and they can be really beneficial in this space. You've also, though, got to make sure you've got the right wound dressing in place to be able to actually control the bacteria and wick away that moisture. That's where super absorbent dressings are really important in this space. Don't think of them as a unit cost is expensive. Actually, anything that you can protect that peri-wound edge is going to be really important. And remember that it takes 28 days from your cells that are produced at the stratum basal to come right up to the stratum cornea in your epithelial skin. So anything that you do today, you're not going to see the benefit for 14 to 28 days. So don't think what you're doing, oh, I have to change again after a week. Give it time, because the cells will take that long to regenerate. But again, whoever's asking that question, you're a great clinician already, because you're thinking about what you're seeing and how do you optimize that patient. But always start with your optimization of what is the underlying cause and have you fully addressed that.
Great, Leanne, thanks very much. I suppose then this is the final question is, what's the biggest misconception clinicians have around wound infection?
Oh, I think there's many. I think there's still a misconception that a patient with a wound requires a wound swab. I think that's the worst thing any clinician who is in wound care can do, because what happens to that wound swab, it flies off to a GP practice. That GP will open that swab and it'll go, there's some strep and some pseudomonas, and they'll throw out some flucloxacillin for that patient. And actually, that nurse may be able to manage that because it's only a local infection with the right wound management strategy, and they never needed antibiotics. What triggered the antibiotics is the wound swab. So I would say if you are a healthcare professional, only take a wound swab when you want antibiotics. If you think you can manage this wound locally, that wound swab is not going to help you in any shape or form. There will be mixed type of bacteria on that wound, and there's often fungus on that wound. So we need to be thinking about how can we manage those locally within the right treatment. I still think that the word infection is linked to antibiotics, both in our clinical mind and the patient's clinical minds, and that's a big misconception. I also think that there is still a consideration that if a patient has got a localized infection, the product that most clinicians reach for is a silver dressing. The evidence base for silver dressings is questionable, along with there is issues being raised in terms of toxicity and resistance. So just be wary of that. And that's why newer, innovative products might be more useful within this clinical space.
That's fantastic, Leanne. Thank you very much. That's the end of the questions and the end of the webinar as well. I think I'll be going and looking at that IWII statement now myself very soon, because it sounds like there's great content in there. Once again, very much appreciate you taking the time out, Leanne, and everyone joining the call. It's been very insightful, and everyone go off and enjoy your evening.
Yeah, and I'd just like to say thank you to you all for attending. You are working in a difficult and challenging healthcare system. It doesn't matter which system you're working in, the complexity of what you're doing is hugely demanding. But remember why you came into healthcare. It is a rewarding job. You can make a difference. You are touching hearts. Never lose that brilliance that you have inside of you. Just strive to do the best you possibly can, because you're all amazing in each and every way. It's been lovely having you here tonight, and thank you so much for HC21 for organising all of